how has technology changed angioplasty over the decade?
So yes, and now we have artificial intelligence coming into these imaging techniques where we don't need a doctor to interpret that image. The machine interprets the entire thing for you.
Doctor, the fit people who are marathon runners, gym regulars are getting heart attack cases recently.
Any form of stress can cause a tear in the lining of
Wearable devices like smartwatches, are they actually able to save people's lives and prevent certain heart attacks?
They do give some element of information, some extra information to the doctors, but I don't think it's time yet to trust them 100%.
So, Doctor, India statistically has more heart disorders in the younger age group as compared to the West.
The visceral fat in Indians will be almost 20% as compared to 7% in a European.
One test which people usually skip but must be mandatory after 30.
Please check your kidney functions once. Please check your liver functions. Please check your cholesterol once.
After COVID, heart attacks have increased in the younger generation. Is it the virus, the vaccine, or something we are missing here? Hello everyone and welcome to the official podcast series of Lilavati Hospital and Research Center. Every heartbeat matters. It powers our every moment. In today's fast-paced world, where everybody, even the younger generations, are suffering from heart diseases, it has become imperative to understand about our heart health. Today, we are joined by Dr. Ajit Menon, one of India's leading interventional cardiologists. With over 3 decades of experience and 10,000 cardiology interventional procedures to his credit, he has been able to help a lot of patients across India. Thank you, Doctor, for joining us today.
Thank you so much for having me over. Thank you.
So, Doctor, cardiology was originally the plan. What pulled your heart towards it?
Actually, cardiology was never my first plan. I was very interested in chest medicine and intensive care, and I wanted to do something in chest medicine at that time. But when we did our graduation, there was only one seat in chest medicine in the entire metropolis of Bombay. So then we gave our entrance exams, and I passed, and the next thing I know, I was on the list, and I took up cardiology because it was something similar to what I really wanted to do, something to do with intensive care, something to do with acute patient care. So that field also was a bit interesting to me. So I decided that I'll take up cardiology, and I don't regret it at all at this point of time.
So, Doctor, with over 10,000 interventional cardiology procedures to your credit, is there any moment or any patient experience you have which remains in your memory till now?
Well, I don't know I never keep numbers of what I do, but yes, I have been in practice for the last 35 years, and if you ask me a specific patient moment, no, there's no specific patient moment, but at the end of the day, what gives us a sense of that we have done something is when a sick patient recovers and goes home. There was this young guy who came in with a cardiac arrest. He was out of the hospital. He had an out-of-hospital cardiac arrest, and he reached almost 40 minutes after the cardiac arrest. Luckily, the bystanders had given him some CPR. We continued the CPR for almost another hour more, and we were almost about to give up. Said it's already 1 hour 45 minutes since the initial episode, and somehow we got his heartbeat back. And subsequently, almost 3 months later, he walked out of the hospital. That was a moment which I felt that we had done something, and the best part was, after going home, after recovering, he went to Kainchi Dham, to an ashram, and got me some stuff from the ashram. That was really heartwarming.
So, Doctor, it's definitely about medical science that the numbers of procedures become routine, but certain moments definitely remains in your...
Absolutely. It's after all, it's about humanity. What we do are dealing with human beings, not inanimate objects.
Doctor, in your 35 plus career experience, is there any change in the way you practice medicine right now?
Unfortunately, there are a lot of, there's been a lot of change in the way we practice medicine, basically because when I learned medicine, when I got into cardiology, there were a lot of aspirations in doing a lot of stuff, and there was a lot of patient-doctor trust in those days. Unfortunately, today what we see is that the trust between the patient and the doctor is something which is a falling commodity. We don't see so many patients who are extremely trustful of doctors, and I think partly it's the community to blame, partly it is doctors to blame. But I think that is something which we need to build all over again and regain the trust that we have lost from the patients. If we do that, then we can go back to practicing medicine the good old way.
Doctor, can you walk through us in one of your cath lab procedures where there's a complex procedure? What goes on in your mind?
When we have a procedure that's a little complex, first of all, the first thought is that the patient comes first. And what we believe is that the patient is there on the bed, on the table in front of you because he trusts you. He trusts you 100%. We should never belie that trust. So when we go in for complex procedures, we are already planning the procedures well in advance. We plan it in such a way that we see what complications we expect, and we are well planned for that. And yes, when things do go wrong, even we have pacing hearts, we have racing heartbeats. We get a lot of anxiety and stress when we're doing these procedures, and it's rewarding, and at the same time it's stressful. When we do extremely complicated procedures, the problem is that we are dealing with the heart, and when we deal with the heart, that's the central engine of the body. So when we manipulate structures into the arteries of the heart, obviously the heart can react very badly, and if something goes wrong, the life of the patient is at stake. It's not that we get a second chance. So we have to be careful about what we do. We have to be careful about how we plan it out and how we do these procedures. And we know that there are certain situations which can crop up, and we need to be prepared for it.
Doctor, since you mentioned about certain situations and you plan a procedure of beforehand, is there has been any instance where you have to change your original plan in between and you have to trust your instinct?
It always happens. Medicine is never mathematics. In medicine, if you put 1 plus 1 in one patient, it becomes 2. In another patient, maybe 5. So medicine is never mathematics. So when we go in to a procedure completely well planned, something will go wrong in between. For example, you may have a small tear in the vessel, or you may have the BP suddenly crashing, or you may have the patient getting breathless, where you change your tack and do something which is appropriate at that point of time. It's not that always what we plan is the way that it goes. So we already have plan A, plan B, plan C planned in advance. What if, and how do we manage it? So complications are a part of procedures, and we need to be aware of it, and we need to know how to tackle these complications and adverse situations that come in.
So what we understand is medicine is usually unpredictable at some time.
Medicine is unpredictable because the human body is unpredictable. We are dealing with a human body which is so complex that I don't think anyone can make you understand it in a single word. Every organ, every system, every cell in the body has its own life, and the whole thing comes together as a human body, right? So, and we as cardiologists are dealing with the central engine. So anything that goes wrong is going to affect all the organs of the body, not just only the heart. So we don't take the heart as a single unit. We always look at it with respect and in perspective of the other organs that it supplies.
So doctor, has there have been a case where the angiogram looked very serious or complicated, but the patient seemed to be very physically well?
There are multiple cases where we find that the patient has multiple blocks, and the patient is absolutely asymptomatic. Just today morning, I had an elderly gentleman, 75-year-old, absolutely no symptoms. He just underwent a regular health checkup. He found something on the ECG, so he went in for a 2D echo and a CT angiography, which showed blockages, and he went in for a coronary angiogram, which shows multiple blockages. Now, for us to explain to the patient that to an asymptomatic patient that, hey, you got multiple blockages, that you need a bypass surgery or an angioplasty, is something which is not easy. If the patient has a trust in you, he's going to believe you. Otherwise, obviously, he's going to take other opinions. So there have been multiple situations that we face in our lives on a regular basis, where the patient is completely asymptomatic, but when you examine him or you find something, you do some investigations, you find that things are not all right.
Through this, we understand that prevention and early awareness always help in preventing such disorders.
Prevention early awareness always helps. So that's why today we have we recommend health checkups to a lot of patients, especially beyond the age of 35 or 40. And if you're a high-risk patient, that means you have multiple comorbidities like diabetes, hypertension, or you have a very strong family history of heart disease in your father or your mother or any of your siblings, then we do recommend that you undergo health checkups at a much younger age. The recommendation now is for patients who are at a high risk or who have very high cholesterol values in the family itself. The recommendation is the first cholesterol check should be done at the age of 19. These are situations where we call them as familial hypercholesterolemia, where the whole family has a history of high cholesterol on one side of the parentage. So in these people, we start checking the cholesterol values at the age of 19. And then subsequently, every 5 years, they undergo a check to make sure that the cholesterol values are not gone up and that they're not harboring any disease which is not seen on the surface.
So, doctor, you mentioned about in a perfectly healthy patients, explaining them regarding the findings which have come in their test. How do you explain such emergency interventions to the patient as well as in the family, and how do you stay calm throughout the procedure?
I mean, it's we're not always calm through the procedure. When we first started off practice, we used to be very anxious and we used to get very jittery doing these procedures. But luckily in my practice, I had my mentor, Dr. Samuel Matthew Calorical, as with me throughout the last 30 years. And that was a great boon because it gave us the courage to handle cases. It gave us, and we learned a lot from seeing him. How do you explain things to a patient? Well, you have to sit them down and as calmly as possible explain to them, because they're also anxious. They also need to know what's happening. So the best thing is to put it up front to them. Okay, this is the problem. This is what you have. And these are the solutions that we have. Sometimes there may be two solutions. The patient may have to choose which solution he wants to go for. It's not always that we have a concrete solution that this is the way to go and there is no other way about it. There are always 2 or 3 ways to manage a problem.
So reassurance is as important as the
Reassurance is extremely important. Making them understand what they have is extremely important. Making them understand the treatment choices is extremely important. Making them understand the pros and cons of the treatment choices and what to expect out of it and what are the possible complications out of a procedure are also extremely important.
So, Doctor, India statistically has more comparatively about heart disorders in the younger age group as compared to the West. What is the reason behind this?
I think genetically, Indians have a trait towards heart disease at a very young age. We have diabetes at almost 5 to 10 years earlier. We have hypertension 5 to 10 years earlier. Heart disease also 5 to 7 years prior to what others in the Western counterparts have. You know, there's a concept which has been laid very long back, and that's called the thin fat Indian. What is a thin fat Indian? A thin fat Indian is a thin-looking Indian individual with the same BMI as a European individual of the same age and the same height. But if you calculate their visceral fat, the visceral fat is a fat inside the abdomen, lining the organs. If you calculate the visceral fat in Indians will be almost 20% as compared to 7% in a European. So that's where the first game starts. We have a very high incidence of diabetes. We have a high incidence of hypertension. Our eating habits, though a lot of Indians are vegetarians, we have a lot of carbs and fats in our diet. Our protein intake is quite negligible, especially for a vegetarian. Now, yes, of course, people have started exercising, but otherwise, previously, that was a little bit of a challenge. I think, and another thing which I would like to point out is basically 2 things. One is stress, and the second is lack of sleep. 2 things that our youngsters today have problems with is stress. Mind you, stress is not the major problem. The reaction to stress is what defines what the outcome of the stress is going to be. And of course, lack of sleep. You need at least 6 to 7 hours of sleep daily, of which at least a couple of hours have to be in the deepest part of sleep. If you don't get that sleep, obviously you have a lot of buildup of cortisol and hormones in the body, which are detrimental to your general well-being and to the heart also in general. So I think if you ask me to point out the major factors, one is diet, amongst them in the fast food and the junk food that people eat. 2, early diabetes. 3, hypertension. 4, family history. And of course, smoking and vaping. Vaping is as bad as smoking. And of course, lack of sleep and stress.
Doctor, these points are definitely an eye-opener to our younger audience who's there. Doctor, the fit people who are marathon runners, gym regulars are getting heart attack cases recently. People assumed that who are fit will not suffer heart diseases. What can be the cause behind this right now?
See, what happens is that you may be a marathon runner or a very fit exercise person, but if you have plaques in your arteries and they are cholesterol rich, what we call as soft plaques, any form of stress can cause a tear in the lining of the artery. Now that stress can be physical, emotional, or even anything else. For example, you exercise much beyond what your body can take. Your blood pressure shoots up through the roof. The plaque ruptures, attracts clots, and the patient has a heart attack. The patient doesn't realize it because all these things happen in less than a minute. And the next thing you know, that the blood supply to the heart, to that part of the heart is stopped. The heart becomes irritable. It goes into a rhythm called as ventricular tachycardia or ventricular fibrillation, and the person has fallen down. So, though this does not discourage people from exercise, but in moderation, or know your limits and what you can exercise. Anything in excess is bad. Even exercise in excess is bad. So most of these people, I presume that most of these people have probably high stress jobs. They have issues with their cholesterol, which they haven't realized it. Or in a lot of situations, they may have had some warning symptoms prior. Like, for example, some burning in the chest or some discomfort on walking, which they thought was acidity, ignored it, and they landed up with the problem.
Doctor, if somebody has absolutely no symptoms, how do they know that their heart is healthy?
The only way to know that your heart is healthy is to test it. So get a routine checkup for the heart. The most common checkups are ECG, a 2D echo, and a stress test. If these 3 things are normal, we can presume with a fair amount of surety, at least 80 to 90% surety, that everything is normal. Having said that, nowadays what we also see are patients going in for a CT angiogram directly. Is it good? Well, I don't think I have an answer to it because it has gone both ways. We have situations where the patient does a CT angiogram and comes to us with the angiogram showing an 80 or a 90% blockage. Would that have mattered? Definitely yes. It could have given trouble sometime. Did the patient have any symptoms? No. He just walked in and got a CT angiogram. So it's difficult for us to say that no, don't do CT angiograms. But advising to do a CT angiogram randomly in each and every patient beyond the age of 40 is not right. There are certain subsets of patients. A patient with a strong family history, patient who's a diabetic, patient who's got hypertension, a cigarette smoker, or a person who suddenly at the age of 40 wants to run a marathon. These patients, yes, I do recommend that in addition to your ECG, echo, and a stress test, go ahead and do a CT angiogram if you want to rule out blockages. But be careful that you don't have a reaction to iodine, which is a contrast agent, and your creatinine or your kidney functions are normal.
Doctor, can you just name one test which people usually skip but must be mandatory after 30?
The simplest thing that you can do is ECG and a stress test amongst the physical tests. You can also do beyond the age of 30-35, please check your kidney functions once, please check your liver functions, please check your cholesterol once. You know where you're heading. You know what needs to be monitored, what needs to be controlled. And then you can decide how you want to go about it.
Doctor, regarding heart attack, which are the symptoms which people usually ignore and skip and do not report at time?
Very commonly, we do see patients who come with a history of they say it is gas and acidity. They say that they have a little burning in the chest. It goes away when I take Gelusil. But sometimes it comes up when I'm walking. It comes up in the night when I'm lying down. These are symptoms which get ignored very often, and they are treated as acidity. Another symptom which also comes into this, which can be missed is jaw pain, exertional jaw pain. When you walk, you start walking, you get jaw pain on both the sides of the jaw. You stop walking, the jaw pain goes away. That's not because of the teeth; it's because of the heart. Breathlessness. Breathless is when they walk short distances, which they had no problem walking a month ago. The same distance when they cover it today, they start feeling breathless. Breathless in the middle of the night. Wake up in the middle of the night feeling breathless. That's another symptom which people think it is basically because of acidity or something, and they just sit up and they feel better. And very often they're treated as asthma or otherwise, but they are typically cardiac symptoms. And especially in women, women may not historically come with the classical symptoms of angina. They come with these vague symptoms of breathlessness or uneasiness, jaw pain, fatigue, extreme fatigue. These are certain symptoms which should not be ignored. If you have it, get it checked up.
This was definitely insightful information for our audience. Doctor, how much exercise is actually healthy for our heart?
I think, I'm not the best person to advise you on exercise limitations, but 5 or 6 days of exercise every week for at least 45 minutes in whichever form that you do is something which is good for the heart. That should be a mixture of aerobic exercises and along with a little bit of strength training, because that is extremely essential for Indians, where the muscle mass is definitely on the lower side, and beyond the age of 50, 55 or 60, we see people losing muscle mass much more faster than their Western counterparts.
Doctor, are there any myths around cholesterol you would like to debunk today?
The myth that people pass on WhatsApp nowadays is that cholesterol is the biggest hoax of the century. I don't believe that, and I'm sorry to break that myth that cholesterol is something which has been studied over years. Yes, cholesterol is necessary for each cell to function. Your brain needs cholesterol, your skin needs cholesterol, all your organs need cholesterol to regenerate and function. But like I said, excess of anything is bad. And when the cholesterol starts actually blocking your arteries and blocking off arteries, that is when you realize that this should have been treated a long time back. So, especially in people with a strong family history or a tendency for a very high cholesterol, the best thing to do is start a good diet, exercise, lifestyle changes, try and reduce the cholesterol down to the limits down. If they don't come down, and if your doctor feels that you're the right candidate for medicine, and that because your cholesterol needs to be brought down, I think the best thing to do is get onto medications. And the other myth that I would like you to bust is that once on medications, you cannot get off medications. Yes, you can, definitely. No one is stopping you from getting your cholesterol down to limits that are defined, that are necessary. And if you can bring it down to those limits with minimal medications, of course we will stop the medicines and see. Why not? We're not married to the medications. We give medications when it's necessary. If it is not necessary and you can manage your lifestyle and your cholesterol by yourself, you can manage your diabetes, you can manage your blood pressure, you can manage your cholesterol on your own, no one is going to give you medications.
Doctor, after COVID, heart attacks have increased in the younger generation. Is it the virus, the vaccine, or something we are missing here?
I don't think we'll ever have an answer to it, because COVID itself was a thrombotic disease. We saw a lot of increase in young heart attacks during COVID. Asking me about the vaccine is a very controversial subject, because I don't think we'll ever know what actually was a better and what actually causes issues. I'm sure COVID by itself also was a disease. I'm sure by way of not very simplistically saying it, but the vaccine. I mean, if you ask me, does the vaccine cause clots? I don't know. I don't have an answer to it. But yes, we do see more youngsters post-COVID coming in with blockages in the arteries of the heart, coming in with heart attacks. Is it because of increased awareness? Is it because of increased scrutiny? Is it because people are getting checking themselves more and more, so they're coming out with more blockages? I'm not sure. I'm not sure I have the right answer.
Doctor, is angioplasty being overused as a treatment or is still the best treatment plan?
No, I don't believe that angioplasty is being overused. I believe that when we have coronary artery disease, there are three modes of treatment. Medical, that's medicines. And when medicines don't work or they do not get you the effective results that are needed, then you either go in for a angioplasty or a surgery. There are certain situations where we would say that surgery is the only alternative, or surgery is a better alternative as compared to angioplasty. There are certain situations where angioplasty would be the best choice of treatment. So these are all defined by a lot of definitions that a lot of situations in what we find with the patient's history and the angiography and various other findings that define which way does the patient go. Angioplasty is not overused. Angioplasty has become an easier mode of treatment, but as long as the patient and the relatives understand what the pros and cons of the procedure are and what is the best mode of therapy for the patient, I think if it is used in the right perspective, angioplasty is an excellent form of treatment.
Doctor, what is the biggest myth patients have regarding angioplasty or stenting when they walk into your clinic?
Angioplasty is not short-lived. Angioplasty is as good as bypass surgery in a lot of situations. And there have been comparative trials which show that both, when you compare angioplasty versus bypass surgery, the long-term results are the same. Yes, what angioplasty has is that about 6 to 7 or 8% of the patients who undergo an angioplasty will come back in the first year with a recurrence. Why so? Because when we deal with an artery, with a blockage inside an artery, we use a balloon to open it up, or we use a stent to plaster to keep the artery open. We are causing injury inside the vessel. And that injury normally heals by scar formation. So when a scar forms inside the vessel, if the scar is excessive, it's going to narrow the vessel down in the first 6 to 9 months. If the scar formation is not much, or the deposition of cholesterol back into the artery is not much, that patient can have a normal life for years to come. So we have patients who have done an angioplasty 20-25 years ago, still absolutely normal. But we need to accept that out of 100, 6 to 7 will come back with a repeat blockage. That needs to be understood.
So doctor, how has technology changed angioplasty over the decade?
How has technology changed angioplasty? Well, a lot. When we first started angioplasty I started in the early 90s. We had only balloons. We didn't have stents. So we had only balloon angioplasty. We used to open up the block and trust me, out of every 10 patients, one patient would have a problem where the artery will close off in the first half an hour or first couple of hours, and we had to rush these patients for surgery, for an emergency bypass surgery. To prevent these acute closures came the stents. Stents are a scaffolding on the artery, which scaffolds the artery and used to prevent these sudden closures. But we found that the recurrence rates were very high. So a lot of genetic engineering on that, and then came the drug-eluting stents, the drug-coated stents. That has undergone an evolution over the last 15-20 years, and we have got much more better and easier to deploy stents. After that came the era of imaging. We have catheters which can go into the artery and have a look inside the vessel. So we have ultrasound catheters which go into the artery and do a sonography of the entire artery from the top to the bottom for us to define how much is the blockage, what is the extent of blockage, what type of a blockage is it. Is it calcific? Is it soft? Is it fibrous? We got a lot of definition of the artery from these intravascular imaging. So one is an IVUS or an intravascular ultrasound. The second is an OCT or an optical coherence tomography. Both work on different principles. The usage of these devices or these instrumentations during a procedure improves the outcome of the angioplasty to a different level. We reduce acute complications. We make sure that the procedure is immaculate, and we make sure that we have done our best in terms of keeping the artery open. This reduces recurrence rates. This reduces acute complications for the patient and makes the angioplasty last longer. So yes, And now we have artificial intelligence coming into these imaging techniques where we don't need a doctor to interpret that image. The machine interprets the entire thing for you, and that interpretation to a large extent is fairly accurate.
So doctor, you mentioned about AI, you mentioned about various technology advancement in the procedures. Is there any old school clinical judgment you feel technology should never replace?
Your empathy towards patients. All right. Artificial intelligence is good in medicine. It gives us, we need to embrace artificial intelligence in medicine. But one thing it cannot replace is our interaction with the patient, our empathy towards the patient, and the way just a touch of a doctor's hand makes a patient feel a lot better. Right? I think that is extremely important, and that's very important in medicine. You can be a wonderful doctor, you can be a great operator, but if you don't have that empathy and understanding and the trust of the patient, I don't think you've made it.
So doctor, we have right now people wearing wearable devices like smartwatches. Are they actually able to save people's lives and prevent certain heart attacks?
No, you can't prevent heart attacks, but yes, it can. Today we have those wearable devices which can predict something called as a atrial fibrillation or a rhythm abnormality. It can serve as an urgent ECG in cases of need, where a patient has a chest pain and he wants to know what's happening. You can record the ECG and send it to the doctor, but then it's a single lead ECG. It does not give you too much of information. There are watches now which measure your SpO2, your heart rate variabilities. They do give some element of information, some extra information to the doctors, but I don't think it's time yet to trust them 100%.
Doctor, what is the biggest mistake Indians are making after surviving the episode of heart attack?
Not exercising. Everyone forgets a patient is a good patient for the first 6 months. After that, he tends to forget that he had a cardiac event. He tends to forget that he's had a heart attack, and stops exercising. His diet goes haywire. Diabetes goes out of control. You need to understand that any patient who undergoes a heart attack and then undergoes an angioplasty or a bypass surgery is, in my words, a glorified plumbing. Right? You're creating new channels. You're creating new pathways for the blood to flow. But if you don't take care of it, it's going to choke up again. Nothing is permanent. So you want to live long after a heart attack? Yes, you definitely can live long. But there are certain issues that you need to take care of. There may be certain limitations, but most of the patients have no limitations in the amount of physical activity that they can do, as long as they train their heart to accept it.
Doctor, after delivering both good and bad news to the families, and with your experience in hand, what has this journey taught you except being treating the heart as a patient and more as a doctor?
It has taught me that to get a good name, you got to slog for years. But a couple of seconds can destroy that name. We have a lot of patients who are so grateful to us, and we are grateful for their blessings. But when things don't go right, it hurts us that sometimes people become violent and physical. Like I said, we never intend hurting a patient. We never intend to do something wrong to a patient. That's not in our blood. We would never do that. But when someone accuses you of something that you haven't done, it hurts. So we take the good with the good, and we understand that we have to take the bad with the bad.
Doctor, what is the last message you would like to leave our audience with?
I think the only thing that I would like to say is that the heart is a wonderful organ. It serves you throughout your life. Remember, it beats 60 to 80 a minute from the time you're born. So just do the calculations. How much has it beat? How many times has it beaten over the past so many years as far as your heart is concerned? Take care of it. It'll serve you well. Exercise regularly. Eat well but healthy. Live a healthy lifestyle. Avoid smoking under any circumstances. Please avoid smoking. Vaping is not good. Vaping also is the same. It's the same as smoking. As long as you can take care of your heart and lead a healthy life, I think all of us will increase our longevity.
Doctor, thank you for joining us, and you've shared a really beautiful perspective. We have talked today about angiographies, angiogram, angioplasties, prevention technology, but one thing which stood out that behind every ECG, 2D echo, or any test, there is a patient with fear, hope, and trust with the doctor.
Absolutely.
And it is as equal importance to treat patient with compassion as much as it is with clinical excellence.
You're absolutely right. I mean, there are situations where we put ourselves in the patient's situation and we think that, hey, and what would go through his mind? What would go through our mind if I'm lying down there, right? And sometimes, even if we want to tell the patient something which is maybe a little harsh, we pull ourselves back a little bit and we approach it in a different way. I think that is something which is not taught in medicine. It's not taught in colleges or schools, but I think it's something which you imbibe on the way.
It comes with experience. Thank you, Doctor, again for joining us today.
Thank you.